Next session is case presentations by our postgraduate trainees. And we have as judges Dr. Sri Lakshmi, Dr. Kumar Divakar, and Professor Madhumita Nandi. Ma'am. Yeah. Okay, so Professor Madhumita Nandi is head of the Department of Pediatrics, North Bengal Medical College. And Dr. Sri Lakshmi is pediatric cardiac intensivist at Amrita Institute, Kochi. Dr. Kumar Divakar, we already had a session with him, so he is the pediatric intensivist at Tata Main Hospital, Jamshedpur. So, our presenters, do you have given the presentation? Yeah. So we have Dr. Shubhajyoti Ghosh and Dr. Vikas KV. So who is starting? You are? Shubhajyoti Ghosh. So Shubhajyoti Ghosh, can you go ahead? It's Shubhajyoti, sir, time for 10 minutes. So 10 minutes, please. 10 minutes. Yes, yes. 8 plus 2. Yeah, I think 8 plus 2. 8 plus 2. Yes. Yeah, we'll give a reminder. 8 minutes, yes. Yes. Yes.
Hello, I am Dr. Shubhajyoti Ghosh, Junior Resident, Medical College, Kolkata. I am going to present oral presentation on impact of fluid balance in outcome of children with acute kidney injury admitted in pediatric intensive care unit in a tertiary care hospital. Introduction. Acute kidney injury is a common and life-threatening condition in PICU associated with high morbidity and mortality. Early identification and management of AKI are crucial for improving patient outcome. Studies have shown that fluid accumulation has a significant relationship with adverse outcome, including decreased renal function recovery and mortality. Objective of my paper is the study was designed to study correlation of fluid balance within 48 hours of onset of AKI and outcome associated with it. Materials and method. It is an interim analysis of an observational study between children between 1 month to 12 years of age who are admitted in our hospital PICU. Study period 6 months. Place of study PICU Medical College Kolkata, and sample size was 34 eligible patients meeting inclusion criteria. Materials and method. Inclusion criteria: children admitted with AKI and children developed AKI during hospital stay, and the patient excluded by the exclusion criteria obstructive uropathy or CKD or CACUT. Then first 48 hours fluid balance estimated from the onset of AKI. Among them, two groups are divided. Group 1 who has more than 10% fluid balance, and group 2 has less than 10% fluid balance. Then the relevant parameters noted for statistical analysis and comparison between two subgroups. And the fluid overload is calculated by fluid intake minus urine output by body weight into 100. Materials and method parameters noted: demographical profile, then disease related parameters like presence of shock, fluid bolus and inotrophs, serum urea creatinine, electrolytes, fluid balance in first 48 hours of AKI onset, ventilation support, organ dysfunction score, that is P-SOFAR score, renal replacement therapy required or not. Outcome parameters were duration of ICU stay, final outcome, that is mortality and discharge. Assessment of fluid overload before developing AKI where applicable. Statistical analysis by SPSS version 23, and for correlation variable chi-square test, and continuous data by mean Whitney U test were used. Acceptable limit of significance p-value less than 0.05. Staging of AKI, that is KDIGO criteria. There is stage 1, stage 2, stage 3, and it is based on serum creatinine and urine output level. Result: Out of 34 children, 4 were excluded by the exclusion criteria, and out of 30 children finally analyzed, there are 12 had AKI on admission, and 18 were developed AKI during hospital stay. Then among the children, stage 1 has most of the cases, 12 children, that is 40%. Then stage 2 were 8 children, and stage 3 has 10 children. And causes of AKI, the most common cause were sepsis, that is 46%, then heart failure, snake bite, and other causes. And hypovolemic shock was 23%, that is 7 of the children. The result analysis parameters. Mean age of the study was 32 months. Then gender, 18 were boys and 12 were girls. Shock present in 13 children, that is 43%. Fluid bolus required 14 children. Inotrope needed 10 children, and P SOFA's mean score was 14. Urea mean 82, and creatine clearance was 26.7. Cumulative fluid overload in 48 hours of onset of AKI, less than 10% was 17 children, and more than 10% cumulative fluid balance was among 13 children. Then pre-AKI fluid overload, less than 10% was 12 children, and more than 10% fluid overload present in 6 children. PICU stay means 12 days. Mortality was 8 children, that is 26%. Ventilation support required IMV, NIV, or nasal prong. Renal replacement therapy required 14 children, that is 46%. Hemodialysis done in 9 children, and peritoneal dialysis done in 5 children. Then comparison of outcome between two subgroups. There's two subgroups. One group has fluid overload more than 10%, and the next subgroup fluid overload that is less than 10%. In our study, we can see that there is a significant positive correlation renal replacement therapy and mortality. The p-value was significant, that is less than 0.05, and who has more than 10%, the renal replacement therapy required in 10 children, and who has less than 10% fluid balance, renal replacement therapy required in 4 children. And mortality was are more in fluid balance more than 10%, that is group A, and mortality was less in who has less than fluid balance less than 10%. And prior AKI development, prior to the AKI development of fluid overload, that is more than 10%. In the more than group A, that who has more than 10% fluid balance, the children was 5, and who has less than 10% fluid balance, the number was 1. But the P SOFA score and duration of PICU stay, the p-value is not significant, but the P SOFA score and duration of PICU stay more in fluid in subgroup of more fluid balance more than 10%. This is a correlation coefficient curve between fluid overload and duration of PICU stay. P-value is 0.003, that is significant. And the discussion, the study demonstrated that early, within 40 weeks of onset of AKI, fluid overload in AKI is associated with significantly high mortality and need of renal replacement therapy. In previous studies, fluid overload were assessed in first 14 days of admission in PICU, which was associated with increased mortality 38%. In our study, we found significant association of mortality with early fluid overload. Studies also found that a requirement of renal replacement therapy is more in patient with fluid overload, 53%, with more P SOFA score, p-value less than 0.001, but there is no correlation between duration of hospital stay with fluid overload. Duration of hospital stay with fluid overload. In our study, fluid overload also significantly associated with a need for renal replacement therapy. However, P SOFA and duration of PICU stay, though more in fluid overload group, but it is not significantly statistically significant. Discussion: previous studies suggest that significant fluid overload may occur prior to development of AKI. However, whether the fluid accumulation is a contributor to AKI is yet to be determined, because that AKI may have occurred before it was detected with current clinical diagnosis. In our study, 5 children contributed to more than 10% fluid overload group who already had more than 10% fluid overload before development of AKI. Conclusion: fluid overload during the early period, first to 48 hours of AKI appears to be associated with higher mortality rates with adverse outcome. The findings suggest the importance of implementing strategies to avoid fluid overload in PICU. Limitation: not able to ascertain the fluid balance before PICU admission for those who admitted with AKI. Because of observational nature, we cannot determine if early fluid overload has a precise pathogenesis in increasing mortality. These are my references. Thank you.
For finishing in time, you have finished before time, and very well formulated study and very relevant also, because that's a common association which we face in ICU care. Just one question I want to ask: have you made any attempt to categorize outcome based on the etiology? You showed that out of 32 or 34 participants which were included, some had heart failure, some were post snake bite or snake envenomation and other drugs and all. So have you made any attempt to categorize the outcome based on the cause or the etiology of the cause of ICU admission or AKI?
Most of the cases, sepsis is the predominant cause, but whether it is related to specific relation with fluid overload with the cause, I cannot measure.
So this is a very small study, and do you plan to have any long-term follow-up of these children?
Yes, it is an interim analysis. So after the study, I will follow up the patient.
Okay.
Shubhajyoti, thank you for the good presentation.
Thank you, ma'am.
Could you go to your first slide? I want to see what your topic is. I just want to read it again. The first slide. I also wanted to ask you, what is your indication for RRT in these babies? When is the cutoff? When do you initiate dialysis?
Stage 3 AKI patient mostly required renal replacement therapy.
So you don't, do you like, okay. Another thing is the fluid load, I think you've already mentioned that it's not necessarily because of AKI, there are multiple causes. So impact of fluid balance and outcome of children in AKI. So then it cannot really be said as AKI, right? Because there's sepsis and there's heart failure, right? So there is a non-specificity to the study, right?
I have not classified according to specific causes.
Okay. AKI due to various causes.
Various causes.
Because when there's heart failure, then the fluid balance, I'm just thinking like that. It's not exclusively because of the kidneys.
Okay.
Right, but the differentiation is not there.
Not done.
Thank you.
Yeah.
Thank you, ma'am.
Very good study. Can you go to comparison group? More than 10% and less than 10%. So, what was the prior AKI development fluid overloads? What does that mean?
Sir, this means this patient before AKI they have fluid overload more than 10%. Before development of AKI, they had fluid overload more than 10%. And in case, the patient, 5 patients among the group who are in more than 10% group, they actually within the, before 48 hours, they had fluid overload more than 10%. And in between these 48 hours, they also fluid overload increased.
So, does this mean before recruitment, 5 have already more than 10% in one group and...
and this one patient who have fluid overload more than 10% before development of AKI, and in these 48 hours the fluid overload decrease less than 10%.
So it means the group who has the less than 10% fluid overload one patient had already fluid overload before the recruitment.
Yes, yes,
so it
sir.
means the fluid you have calculated only for 48 hours, right?
Yes, sir.
So from the recruitment to the 48 hours. So if a patient has admitted in the ICU, stayed for 3 days and then developed fluid overload, so your total 10% you are calculated in the 48 hours from there 4 day 5. You did not consider the previous fluid overload,
No.
right? Okay. Thank you.
Thank you, sir.
Jyoti, one more thing. So when you initiate RRT, don't you target a negative balance? I mean, why were the patients still fluid loaded? I mean, I'm just asking. Right.
Yes, my target during RRT, the target is to maintain negative fluid balance.
But you still had positive, right? Or is it because, I mean, what is your, how do you target your RRT? Like you target for a negative balance, or it's just the creatinine, the solute clearance? How is it? Because I'm asking you, like, what was it in your study? What did you do?
The target outcome of your RRT, is it the creatinine level or the negative fluid balance, or what do you target?
My target to maintain the fluid balance because
Have you documented negative fluid balance during a RRT?
Yes.
You have not shown that. That's what madam is asking.
Okay. That document
Because the
is
whole point of initiating RRT is not to have a fluid overload, right? But you still, I'm just asking because you have some considerable amount of babies are still loaded even after your RRT initiation. That is why I'm asking, like, how did you go about it? What was your target? Did you target a negative, or was it?
my target is negative to maintain negative fluid balance, but I have not shown here. Yes.
Okay.
Thank you, ma'am.
Thank you for your nice presentation. I would invite our next speaker.